On behalf of the American Academy of Neurology and in partnership with Neurology Today, it gives me great pleasure to introduce Dr. Winston Chiong. He's an associate professor at the UCSF Neurology and Memory and Aging Center, and he's a member of the American Academy of Neurology Ethics, Law, and Humanities Committee. Winston, thanks so much for joining. I'm sitting in New York City, the heart of, I want to use the word insanity, epicenter, whatever it is. Never in a long time or a million years did I think that we'd be sitting through an event like this, where you and I would be talking about allocation of scarce resources. You told me earlier you're a member of your hospital's triage and allocation task force. I can't even believe those words are coming out of our mouth in the United States of America. From an ethical perspective, COVID-19 is it's just an unprecedented situation. Maybe you could just start off by giving us just a little bit of an overview of ethical considerations around COVID-19, and then how a neurologist in an inpatient setting or outpatient or whatever really has to think about allocation of resources in this time.
I entirely agree with what you say, and I think that we have colleagues who work in international settings who are more familiar with the idea of working within scarce resources, and it's a really alien thought to a lot of kind of the way we've been trained in American medicine, for better for worse, really. And we've always kind of practiced just with the patient in front of us, and tried as much as possible. And I think to some extent we've been maybe unrealistic in certain respects, but as much as possible we tried to leave out considerations of scarcity and not think about does this patient in front of me need this resource more than somebody else who might get it. And again, some people might say that that's been a blind spot of ours, but that's really the way that we have practiced. That's the way we've been trained to practice, and and we've been able to do a lot of good in that way. And one of the things about pandemics and these other sorts of crises is that they really do make us shift the way we think about our work and the way we think about medical resources. And so on one hand, I'd say that it's true that it's hard to believe that we're here. To be honest, there have been a number of bodies that have been planning for something like this. And, we've had these sort of early warning events with H1N1, with SARS, with other kinds of, zoonoses, other kinds of new infectious diseases. So, there actually has been a fair amount of preliminary planning that has, taken place in the last couple of decades in particular, thinking about what we might need to do. But at the same time, it does feel unreal that we're in a situation where we are very realistically talking about, what do we do if we don't have enough ventilators? What do we do if we don't have enough PPE? What do we do if we don't have enough staff, respiratory therapists, people like that, to care for these people who are really, really sick, and many of whom, it seems like are going to require critical resources, potentially for weeks at a time.
Yeah. And, I went through this with a family member recently, it's actually about 10 days or so ago, it was last weekend, where my brother's mother-in-law was having shortness of breath. They called the ambulance, and then first you have to realize, wow, once she goes in, she's by herself. That's like that's a whole, whole thing. She goes in, and, luckily it was a local hospital, a good hospital, that I had a, connection there, and someone just walked by her room, and, she was on a face mask. And I guess she was on 100% O2, non-rebreather or something like that. I'm forgetting the exact specifics. And she was just in a solo room, on the regular floor with a face. And it's like, you say to yourself, well, wow, they're keeping her on a face mask. Shouldn't you do like a test or like an ABG or something? But they just couldn't. There was too many patients. There were too many things going on. And just to see this with your own family member, that, one of the things I think you mentioned is like the crisis standard of care. And this is a crisis, and we expect one level of care in one regard, but then this concept of a crisis standard of care, I mean, that's a term that's never even occurred to me. Maybe you could talk a little bit about that.
It's a controversial term, I'll say, and I think that there are some people in ethics who disagree with it, but whether or not some of this is just really semantic, in terms of talking about whether we're using the same standard of care, but we have to apply it differently, or, but I think it's worth recognizing that this is really a fundamentally different situation than we've all been trained to practice in. And one of the big shifts is that ordinarily, when we are working in medical ethics, if you ordinarily call an ethics consult and we talk you through what's going on in a particular case, we're really, one of the things about medicine is that we have this, real focus on the individual patient. And one of the things that a crisis like this really necessitates, I think, is a little bit of a shift towards thinking more in terms of public health ethics. And so, to some extent, we are adopting a framework within medicine that is more familiar to our colleagues who work in public health. And one of the things that it requires us to do is to think about medical care, to think about critical care, to think about these critical resources in terms of serving a common good. And here we're trying to save really as many people as possible. We're trying to do as much as we can for the whole community. And again, I think to a certain extent, medicine should always have an orientation that's focused a little bit more broadly than just exclusively on the patient in front of you. But I think there's a little bit of a, even not just a little bit, but a really big shift in emphasis and thinking about how do we leverage the resources we have and make them go as far as they possibly can to save the broadest group of people, to really serve the public in this very wide-ranging pandemic.
Yeah. And again, I just still just have to take a step back and say, wow, I can't believe we're talking about this, but we are. This is reality. I've seen this in my family at a local hospital. I've seen this in our hospital, which is holding its own, but extremely overwhelmed. Beds everywhere, people being redeployed. And I just want to just pause and just repeat something you just said, because it's just really impactful and really important. Shifting from a patient-centric ethic to a public health ethic. Thinking of medical care as a common resource to serve the public good. I mean, that's really important to think about. And, I think, neurologists and just medical practitioners on the whole that are on the front lines, shifting their thinking and thinking about this, beforehand, I think will lead to better patient care outcomes for sure.
Mm-hmm. Yeah. And that's another thing that's worth talking about is that, in many places around the country are not as affected as New York. And, we don't know whether they're just a few weeks behind or something like that. But, I think that it is really incumbent on clinicians everywhere, neurologists and members of other specialties to do some anticipatory planning. And, we always talk in other contexts about hope for the best, plan for the worst. We have a really clear sense of what the worst could look like, not just New York, but thinking about places like Italy, like China, like Spain, where these resources really have been overwhelmed. And, I think one of the big lessons of, all the work that's been done in terms of anticipatory planning, like anything else, is really that we have a duty to prepare for worst case scenarios. You have a duty to think about, right now, our hospitals in the Bay Area are less affected than in New York. We hope that stays that way. But, we also know that we are, one or two unlucky events, one or two bad weeks away from facing these kinds of challenges. And so, as uncomfortable as it is, as painful as it is to think about, as many sacrifices as are being demanded right now of community doctors, of community hospitals, of academic hospitals, we really do have a responsibility to the public, but also to kind of the frontline clinicians and staff to be as prepared as we can be, and to think about some of these worst case scenarios before they happen, and anticipate what we might need to do.
Yeah, and the duty, it's our duty to plan. And again, I just never really thought about this in much detail. This is your wheelhouse, this is your specialty, and this is important. But one thing I wanted to chat about, related to this, is about the transparency in determining these protocols. I read, this is weeks ago now. In Italy, and I may be paraphrasing, but in Italy, if someone was above the age of 80. Age alone in a certain hospital or a certain environment, or they got to a point where above 80, that they just couldn't give a ventilator. Yeah. And you hear that and you're like, wow, I know some really vivacious 80-year-olds. I mean, I know some of my patients are 85 or 90 and they're I don't want to say the prime of their life, but in some ways they are. They're amazing. They're sharp. They're engaged. They're adding value to the world. So this transparency in determining protocols is tricky. At our hospital, again, doing an amazing job for all things considered. And there are protocols and they are transparent, but for the deeper, more, I don't want to use the term controversial, but the more difficult decisions, they have phone numbers instead. So let's call an ethics consult, get the humanities, group
Yeah.
and the ethics committee to jump in and to give, qualified advice, and, have multiple doctors that are required to make a decision. So, it just, I guess, defrays some of the burden and whatnot. But I guess when it comes to transparency and determining protocols, as physicians, gosh, what we put in writing, from a legal perspective is, gosh, worrisome. And I think I don't know if you saw, but there was a law firm in Illinois that put out an ad that says, has your loved one been denied a ventilator or care from the COVID-19 crisis? If so, call us and, we'll sue.
Mm.
Wow. So, I think some states are talking about, putting in place, I don't know if the right word is tort reform or immunity, sovereign immunity, whatever it could be called. Just talk to me a little bit about the ethical implications, the legal implications about this transparency in planning and determining these protocols.
Yeah, and I'll take a step back and say first that I'm not a legal expert,
Okay.
and a lot of the ethical issues I deal with are really more traditionally outpatient ethics, and again, there's very few people who have expertise in this issue particularly, but many of us at all these different hospitals are getting up to speed, and of course it's incumbent. Every hospital pretty much has an ethics committee, and every ethics committee at every hospital should be thinking about these kinds of issues. So a lot of people like me are studying up as quick as they can and trying to get expertise in these areas.
Sure.
I think that some of the things that have been done in other places would not fly in the American legal system and would conflict with certain aspects of American culture, American political culture, American legal culture. And I do think that there and again, I wouldn't want to criticize outside of other cultures, and again, people who've been in very difficult situations, but I think there's a number of reasons why in the United States we would hope to avoid any kind of broad exclusions that are on the basis of any particular characteristic, and particularly for what are legally protected characteristics like age. So it should be said first of all that a lot of work has gone into a number of protocols that have been put together by groups with public input, again just in hypothetical situations, but again there's been a fair amount of planning that's been done. And so one of the first things that I would stress to anyone who's on a hospital ethics committee or is thinking about this kind of response for a hospital or a region is that don't reinvent the wheel, don't start from scratch. There's a lot of good work that's been done by broad organizations that have many stakeholders input, and including public input as well. And resources I direct people to, the states of Maryland and Pennsylvania have protocols that have been developed that include input from members of the community. There are chest guidelines from the American College of Chest Physicians that were also endorsed by a wide range of national and international bodies that include multidisciplinary expertise. And there have been a number of other reports, I believe, from the Institute of Medicine and other places, again trying to think ahead. All these protocols have to be adapted somewhat because they were set up for hypothetical situations, and there's certain things that we know now that we're faced with COVID-19 that that circumstances are a little different, right? So for instance, the lack of a pediatric prevalence that changes things a lot ethically. And so all of the protocols that have been developed need to be adjusted to account for the specifics of the pandemic that we're in. But I think that one way of really promoting transparency is to rely upon documents that have been created with public input in mind and that are publicly available, right? So one resource I'd also point people to is that there was a editorial by Doug White and Bernie Lowe in JAMA a couple weeks ago, and the supplement to that actually included a copy of the protocol that's being used in Pennsylvania, and that really can be, it's intended to be adaptable by other health systems. And that has a lot of details about who makes the decisions. We don't want kind of the bedside clinicians to be making rationing decisions. We want them to be thinking about their patient. And so they talk about creating an independent body within the hospital that really has centralized authority over decisions to admit people to the ICU or not. Right. So again, it's not the individual doc who's making the decision. It's really something that's more at a committee level again, for reasons of transparency and getting away from bias.
Yeah.
A number of the protocols, including this Pennsylvania protocol, have different scoring systems in place that take into account, both how likely it is that somebody will survive the current event, as well as how many life years we'd be preserving by saving that person. And I think that in a lot of the protocols that have been discussed, age or life stage, because numeric age, in terms of if one person's 72 and one person's 69, that's not something that should be a determinative factor.
Yeah.
But an explicit criteria are kind of published. They're generally available, and they're things that not just doctors can read, but members of the public as well.
Great. Well, that was super helpful and super informative, and it's really great, and it's I think transformative and really important that all these hospitals are sharing resources. States are sharing these types of resources. Usually, these are types of policies that are like underneath the hood, and no one's gonna no. The lawyers say no. This is a hospital policy, but I was reading online. I think the Surgeon General said something about this or talked about it, that hospitals are sharing these policies on social media. To try to get the word out. I can't even believe that. The most, challenging and in some ways controversial aspects of what we do, we're sharing them because we have to start a conversation around them.
Yeah.
It's really, really
important. And I think there's a lot of very justifiable fears that people have. When we talk about allocation, we talk about rationing, and we have a painful history in this country, as well as in many other places, where people from marginalized groups have been denied access to important resources. And so, it is really incumbent, for purposes of public trust, and also just for really grappling with that history, to try to, be as transparent as we can be about what criteria will be used, and to think about things like disparate impacts on, people who are chronically disabled or people who come from marginalized groups. And of course, we've already seen in the case of the COVID outbreak that the impact has been greatest in Black and Latino communities. And, it's really laying bare a lot of pre-existing health inequities. And, I think we want to be really cautious when we're thinking about protocols, again, if we ever get there, and hopefully we don't, for allocating critical resources, that we want to have particular scrutiny on protocols that would have a disparate impact on these communities that are already disproportionately affected.
Yeah, and related to health disparities, just this last week, there's been so many studies that came out. Actually, I interviewed Maisha Robinson from Mayo Clinic in Jacksonville about this just yesterday, and that video is going to be up on YouTube also. So if someone you can, the AAN members can definitely check it out. We take a really deep dive. I just could not believe the statistics. Something like 70% of the fatalities to COVID-19 in Chicago were African Americans, but African Americans only make up 30% of the population. And these statistics have been mirrored in Philadelphia, Detroit. I mean, and there's probably a lot of reasons and a lot to unpack there, but Dr. Robinson and I got into that, and that's a really, we got to figure this out. We need to address it for sure.
Right. It's really exposing a lot of the problems, that previously existed in our health system and, in our broader society. And I'm looking forward. I didn't know about this video. I'm looking forward to when it gets posted.
Great. Absolutely. So I feel like we could talk for a long time. This has been really high yield, really impactful. I wanted to close on one thing, and that's code status, talking about code status for a disease that, we just conversations that are difficult, number one, but conversations that's difficult made even more challenging because it's a disease that we don't really understand fully, especially the long-term implications. When initially I heard, 80% are fine and most people are fine. Yeah, but that's 1 out of 5 means they're not exactly fine. 1 out of 5 people are going to the hospital. 5% of people are in the ICU and intubated. I mean, that's not fine for me. That's a big thing. But then the recent studies have been showing, that 19% of people in one study had persistent lung changes and abnormalities, weeks after. And wow, I mean, that's wow. If millions of people get this and 20% get a persistent lung problem, I mean, so when you're talking about, prognosis, both acutely and then over the long haul, and you have murky data that we just don't understand. And we want to try to talk about code status with a patient and a family. That's the first part. And the second part is, When you're talking about code status, you're usually in the room with someone. You're making eye contact. You're face to face. You're next to someone. You can just feel the presence and just be there personally. These conversations aren't happening in person anymore. These conversations are happening, sometimes via video, FaceTime or whatever else, but oftentimes by phone. What strategies do you potentially, recommend for these very challenging situations when talking about code status, when someone is, either being admitted to the hospital or ideally, maybe these things should be
Yeah.
brought up before the person even gets sick and the wishes are documented. What are some kind of best practices here?
Wow. I think that we know from all the work that we all do in advanced care planning that the best planning doesn't occur in a crisis. And when somebody's admitted in the ER, and this crisis in particular, because it limits the number of family that can be at the bedside, it limits our ability to communicate with people, it limits our ability to do some of the digging we would ordinarily do to understand what somebody's values are, right? So somebody who's in a bed by themselves on a non-rebreather, with no family around, you have such a stripped bare sense of who that person is outside, and if that person's having difficulty talking, it's just a terrible situation to try to figure out some of this really important work. And we also know that the best decisions are not made under this kind of time pressure, right? So when you've got somebody who's already had significant work of breathing, they're tiring out, things like that, that's not the situation that you want to be in with regard to code status.
Right.
So I think that really as much as possible, the best practice is and encouraging the patients we see on the outpatient side to think about what they want their care to look like. And again, we know a little bit more about what it might be like to be intubated for something like COVID. So I think that those of us who see patients on the outpatient setting, it's probably a good idea to have conversations about what they would want if they were infected. And I think knowing that it's less hypothetical in this case, that sometimes we talk in very broad terms about if you had a problem where you had trouble breathing, like a pneumonia or something else.
Right.
In this case, we can anticipate that people who go in the ICU may be in for a matter of weeks, that they may be very, very isolated, that they may not have family by them. So that's one, I think, consideration to take into account. I think it's still a little early to think about kind of prognostic data for people who are in the ICU, and of course those outcomes seem to depend a lot on the broad kind of capacity within the hospital. So I think there's a big difference between what somebody's chances are in a best case scenario and what someone's chances are in the case of a surge.
Yeah.
And I think when people are stuck with trying to make a decision with a patient who's in the hospital, again, I think that people have had to get very creative in terms of using FaceTime, using other methods of video to include patients, include family members in these consequential conversations. But it's worth being very frank with people about first the fact that overall prognosis has not been great, and also that if somebody does require resuscitative efforts, that that there are going to be a number of factors that will make it less likely that a code will be successful, right? So one of the concerns that we've talked about in our hospital here is just the need to protect staff. And so you have a code team, it's not going to look like a normal code where you've got 8 or 9 people rushing in. You're going to have people who are going to have to don protective equipment. I think it's going to be necessary in a lot of hospitals to limit the number of code responders for patients in isolation, partly to protect staff and partly to preserve PPE. And so, I think another thing that families and patients will need to be aware of is that the likelihood of success of resuscitative efforts is likely to be hindered, because of all these other precautions as well.
That's great. Winston, thanks so much. That was like literally, I think we hopefully hit every single aspect we could have possibly hit. Super informative. People watching, if you're interested in a specific topic, you want to learn more, you can shoot us an email at elearning@aan.com. Winston, thanks for your time. And also please thank your governor next time you see him. He sent us 500 ventilators yesterday to New York City. So we appreciate California, the left coast, East Coast, West Coast, whatever we call it, we can all get along. So I really appreciate that. And
I think that's a good illustration of the idea that these are common resources, and it's a matter of achieving the common good.
exactly.
And I think it's a good sign, at least for those of us in California, that we feel comfortable doing that. And of course, if the situation were ever reversed, we're all in it together.
We're coming right back out to you for sure. So all good. Thanks so much, Winston. Really appreciate it.
Thank you. This has been a great conversation, and thank you so much for doing this.
Of course. Thanks so much.